We'll go ahead and get started. Welcome to Smilow Shares with Primary Care. I'm Karen Brown, a primary care internist at Yale, and this talk is a collaboration between our primary care clinicians and Smilow Cancer Care. Ann Chang, the Associate Cancer Center Director for Clinical Initiatives, and I developed this online lecture series, and we are happy to present today's topic, which is breast cancer screening and diagnosis. Smilow Shares with Primary Care is a monthly Zoom talk directed to primary care clinicians. Our perspective in cancer care is distinct in primary care as we are constantly providing advice to prevent cancer, testing to screen for cancer, and less often actually finding cancer. But when we do, we want to be super efficient to get our patients to the treatment that they need, recognizing it as an emotionally vulnerable time. So we're delighted that Ann and our oncology colleagues are interested and willing to help us explore and support this interface of care. During the talk, please feel free to enter questions into the chat. I'll monitor it and post questions for our speakers during or at the end of the talk when we try to save time for questions. Today, we have three speakers. I'll first introduce my primary care colleague, Jill Banatoski, and then Ann will introduce our other speakers. Jill earned her medical degree at the University of Connecticut and completed her internal medicine residency training at Mass General. She practices primary care general internal medicine with Northeast Medical Group of Yale on the Connecticut shoreline and has had the privilege of caring for generations of families. She's especially interested in preventive care. She's also an assistant clinical professor of medicine at Yale. Since 2020, she has served as the medical director for University of New Haven Health Services, and she is now the director for primary care for Northeast Medical Group. Ann?
Thank you. So happy to be here, and thanks for many of you for dropping in, and I see some names that I recognize. I have the honor and privilege to introduce my colleagues, Dr. Mariya Rozenblit first. She's an assistant professor of medicine and cares for patients with a clinical focus with breast cancer at Smilow Cancer Hospital in Greenwich. She completed her fellowship in medical oncology hematology here at Yale, her residency in internal medicine at NYU, and received her medical degree from Icahn School of Medicine. She's involved in educating medical students, residents, fellows at Yale, and outside of the clinic, her focus is on translational research with an interest in biomarker-driven trial development in breast cancer. In 2020, she was the recipient of the ASCO Conquer Cancer Foundation Young Investigator Award for her project using single nucleotide variants of high functional importance to predict the risk of developing breast cancer in young women with high-risk family history. That's definitely a mouthful. In 2022, she was the recipient of the Susan G. Komen Career Catalyst Research Grant for her project curing de novo oligometastatic HER2-positive breast cancer. And this grant is to foster promising breast cancer researchers by providing support for up to 3 years. I'd also like to introduce Dr. Alyssa Gillego, who's an assistant professor of surgery, surgical oncology, and cares for patients at Smilow Cancer Hospital in Greenwich. Dr. Gillego received her medical degree from Far Eastern University in the Philippines, did her general surgery residency at Maimonides Medical Center, and then completed a breast surgery fellowship at Beth Israel Medical Center, St. Luke's Roosevelt Hospital Center. In 2019, Dr. Gillego was nominated for the Greenwich Hospital Physician in Care Award, and prior to joining Greenwich Hospital, she practiced at Mount Sinai Beth Israel and was an associate professor of surgery at the Icahn School of Medicine at Mount Sinai. Dr. Gillego performs breast biopsies, lumpectomies, mastectomies, sentinel lymph node biopsies, in addition to nipple-sparing mastectomy for cancer patients and women undergoing prophylactic surgery. Her goal is to provide the highest quality of care to all her patients using a multi-D individualized approach. So we've got a super program, and I'm going to turn it over to Dr. Banatoski.
Thank you, Ann. So we're excited to present this program to you. The three of us have actually been part of the care signature pathway formation for breast cancer at Yale, and we'll have snippets of those conversations as well during this talk. Just to give a little bit of background, breast cancer is the most common cancer in women in the United States after skin cancer. It is the second leading cause of cancer death in women after lung cancer. The American Cancer Society estimates for 2025 are for over 300,000 new cases of invasive breast cancer in women and 59,000 new cases of DCIS. And it is estimated that over 42,000 women will die from breast cancer in this year. The median age of diagnosis is 62, and the average risk of developing breast cancer in their lifetime for US women is 13%. Black women have the highest death rate from breast cancer and a higher risk for triple negative disease. So just to give some background, some facts and figures. We're going to talk today in each of our 3 cases about breast cancer screening modalities, mammography, digital mammography and tomosynthesis, ultrasound, breast ultrasound, and MRI.
So mammography remains the gold standard for detecting the early diagnosis of breast cancer. 3D mammography is also called tomosynthesis. And for those women who have dense breasts, it's recommended that she undergo additional screening every year with annual ultrasound if she's dense. We also use breast MRI for women who are at high risk for developing breast cancer, and that's with an annual MRI at 6-month intervals with a woman's mammogram and or ultrasound.
Thank you, Alyssa. Recommendations for different societies based on women's average risk of breast cancer vary across the societies. United States Preventive Task Force recommends 2 years for a frequency of screening, followed by other institutions such as the American College of Obstetricians and Gynecologists is 1 to 2 years. American College of Physicians follows the USPTF at 2 years. American Cancer Society breaks it down to 1 year for women between the ages of 45 and 54 and 1 to 2 years over 55. American College of Radiology recommends a 1-year interval for the frequency of screening, as does the National Comprehensive Cancer Network. So we do have conversations about this. Many of the primary care community follow the USPTF guidelines, and as well as the ACP guidelines. And then our oncology colleagues and our surgical colleagues often are following guidelines for 1 year with American Cancer Society. Alyssa or Mariya, did you want to make any comments?
So I completely agree. The oncologists and surgeons followed the cancer guidelines, which are for annual screening. And even if you look at this table, this is talking about women who are at average risk. So as we'll talk about, the number 1 step is to assess what risk category somebody is in. And so if somebody is at an increased risk for breast cancer, this doesn't even apply to them. And the other thing that I will mention is if somebody has a history of breast cancer, whether it's early stage or DCIS, that automatically puts them at an increased risk of recurrence. And so they certainly follow the 1 year imaging or more frequently, as we'll discuss, for high risk women.
Thank you. And as Dr. Rozenblit said, the first step is really risk assessment is the key to screening strategy. So really assessing personal history, family history, utilizing models for risk assessment, such as the Yale model, the Tyrer-Cuzick model, and then consideration for genetic testing in your patients as well is important based on their family histories.
Yeah, so in my practice, when I see patients who might be at increased risk for breast cancer, there are 2 main models that I use, and the first is Tyrer-Cuzick model. So this is a model that's really based on family history. You can Google it, it's available, and the website referenced here is kind of the most thorough software that's available. It asks multiple questions such as, what is the family history? And it's really important to put in both sides, so maternal and paternal. And it's also really important to put in healthy relatives as well as relatives with cancer. And of course, we're mostly looking at breast cancer, but also ovarian cancer. And there are other cancers that can run together genetically as well. Other things are important too, such as their breast density. So this model will ask if you know what the breast density is. So if a woman has had breast imaging in the past, that's usually written in the report. And if they have very dense breasts, that will slightly increase their risk. And then other things such as when they started their period, where they are in terms of premenopause, perimenopause, or postmenopause, how many pregnancies they've had, and at what age those pregnancies happened. Taking all of that together, it will give you a lifetime risk score as well as a 10-year risk score. The lifetime risk score is considered elevated when it's greater than 20%. And if it's above that cutoff by NCCN guidelines, which is the National Comprehensive Cancer Center guideline, that will make them eligible for additional breast imaging. So in addition to annual screening with mammograms, we also do annual screening with breast MRIs, and we stagger that by 6 months. So we space it 6 months apart. If the 10-year risk is greater than 5%, then we also talk to these patients about chemo prevention. And what we mean by that is we have estrogen receptor blockers like tamoxifen or aromatase inhibitors if they're postmenopausal. And these are pills that they can take to reduce their risk of breast cancer by about 50%. So Tyrer-Cuzick is the best model we have. It integrates family history as well as some of the hormonal risk factors that we talked about. It's very detailed, but it's also very time intensive. So just something to think about. The other model that we have available is Yale. Yale is very short. It's very easy to use. You can also Google it, and it's a pretty easy calculator to use. It does not really estimate risk very well based on family history. It doesn't go into extensive family history, but it's very good for estimating risk if somebody has had a previous biopsy and if they've had any kind of atypia on that biopsy. And so we'll base the risk mostly based on the biopsy results, as well as some of those other risk factors like we talked about, like when period started, how many pregnancies there were, things like that. And if the 5-year risk comes back as greater than 1.7%, then that makes them eligible for the chemo prevention pills that we talked about. In general, the Tyrer-Cuzick model can overestimate risk for patients who have had previous abnormal biopsies. So in general, we recommend kind of estimating a score for these patients, putting in the biopsy results, and then also calculating it without the biopsy results. And that way you can give the patients a range, because neither of these calculators is perfect. And that number that it gives really is an estimate. It's not an exact number. And then Yale is really helpful to use for patients who don't have an extensive family history of cancer, but maybe have had atypia in the past, and you can use that to estimate their risk.
Thank you. Can you talk about, are there any age restrictions on using the models? Is there an age that's too young to use the models?
Yes, absolutely. Thank you for bringing that up. So there is an age that is too young. And in general, we think about patients having to be at least 25 or older for us to even think about starting to use these models. And actually, when you go into these calculators, it will actually give you a little bit of a warning message will pop up if the age that you're putting in is too young. And the reason why we do that is because risk of breast cancer really is very closely tied to age. And so even though we want to identify these patients early, there's a certain age at which breast cancer risk starts, and it does not start before. It's very, very rare for us to see patients younger than 25. And the other thing is, for breast imaging, young women have very, very dense breasts. So we don't want to start imaging them too early as well.
And then,
Thank you. Oh, go ahead.
sorry, I just wanted to add, I don't know if Mariya mentioned, but the risk has to be recalculated. We recommend recalculating the risk every 5 years because a woman may have additional family members get diagnosed or additional biopsies. So we recommend repeating the risk evaluation every 5 years.
Which is just a good recommendation regarding reassessing risk over time, over the lifespan of your patient. So our first case is a 42-year-old woman with a family history of breast cancer. So she's 42, G3P2. She has a history of DVT with pregnancy and GERD, and she presents for routine care. She is on no medications, but she does have a Marine IUD. She's a phys ed teacher. Has moderate alcohol use, non-smoker, married. Her family history is quite compelling. She has sister and brother, no cancer. Mother had breast cancer at age 40 and died of pancreatic cancer at age 62. Her maternal uncle and aunts did not have cancer. As you can tell, this is a patient that did go through the Tyrer-Cuzick model, given that we have all of this data here, just highlighting the importance of having all the data from all the different relatives so the denominators are correct. Her maternal grandmother and grandfather both had lung cancer, no cancer in her father or uncles. Paternal grandmother had breast, and her paternal grandfather had prostate cancer. She had an unremarkable exam. So the first question is, what should we order for breast cancer screening? And just the concept of assessing her risk and consideration of screening studies. So this is a snippet from our breast cancer care signature pathway for screening for women 40 years of age and older. And really, it starts with the family history in this case, for personal and family history for sure. But this is assuming that this person does not have cancer at this time. And you can tell here that she falls into the category where she has greater than or equal to one close relative on the same side of the family with one of the following cancers: male breast, ovarian, pancreatic, high risk prostate, or breast cancer. And so she would, in the pathways, she would get shuffled right to genetic testing evaluation, which is one component of risk assessment that we can utilize. Certainly knowing our patient's genetic risk and if they have any markers for breast cancer is going to change our screening strategy. But even in patients who have genetic testing and have negative genetic testing, they still may be at increased risk for factors that we just don't have the answers to at this time. And as you can see, the other notations there are breast cancer in a first degree relative less than 50, which she had as well. Any known germline mutations or multiple diagnoses of breast or prostate cancer on the same side of the family, suggesting a syndrome. So along with risk assessment from genetic testing, risk assessment from the models that Dr. Rozenblit discussed already, and just as an opportunity to see if there is an increased risk of breast cancer greater than 20 or 25%, depending, will make those patients eligible for more advanced screening. This particular patient, when her data is put in the Yale model, has a 5-year risk of 1.4%, a lifetime risk of over 20%, and in the Tyrer-Cuzick model has a lifetime risk of greater than 22%. Unfortunately, on her screening mammogram, which was on time in annual fashion, she had a mass in the right breast with a spiculated margin, and ultrasound showed a lobulated mass with a high suspicion for malignancy. She had moderately differentiated invasive ductal ER was a low positive, PR negative, and HER2 positive. She underwent mastectomy and was found to have poorly differentiated disease at the time of surgery with lymphovascular invasion, with lymph nodes positive for metastatic disease in the axilla. Left mastectomy, which she opted to do for prophylactic reasons, was negative for any disease. She interestingly had negative genetic testing, but this highlights a case of someone who merits advanced screening. She underwent neoadjuvant chemotherapy followed by surgery, radiation, and has continued on chemotherapy in the year following her treatment. She does have 2 daughters, and so maybe Dr. Rozenblit, would you like to discuss what you would do for her and her next of kin?
Yeah, absolutely. So in these cases, it depends on how old the daughters are. And if they are in their late 20s, early 30s, we would refer them to a high-risk clinic, which we have here at Greenwich and as well as several other locations throughout our network. And that's specifically where a provider would go through the high risk assessment with the daughters as well, go through the calculators with them, and most likely they would be eligible for early screening. So starting at an earlier age, we usually start 10 years before the diagnosis of the relative, which in this case would be the mom. And then they would probably be eligible for the addition of MRIs in addition to annual mammograms. And we would follow them closely. And then if they are not interested in childbearing or finished with childbearing, then we would offer them the chemo prevention if they meet the criteria for that as well, with tamoxifen if they're interested.
Thank you. That brings us to case 2 and Dr. Gillego.
Case number 2 is a 34-year-old African-American woman who first presented to her gynecologist with a worsening case of eczema. She had a long history of eczema, and her dermatologic condition worsened over both nipples, over both bilateral breasts. And when she saw her gynecologist felt a mass in the breast. There was a 2-centimeter mass in the upper outer quadrant of the right breast. And she went on to be referred for a mammogram and ultrasound that confirmed the presence of an irregular mass. So we do have a clinical pathway at Yale, and the clinical pathway is called abnormal breast symptom exams, initial imaging recommendations. I think in general, if a patient comes to your office and she's under the age of 30 and there is a concern, or the patient feels a mass, or if you feel a mass on exam, the recommendation is to order a breast ultrasound. If a woman is 30 years or older, I usually recommend that that patient who's never had imaging before be referred for bilateral diagnostic mammogram and ultrasound. On the right side, you can see a photo from the abnormal breast imaging and symptoms pathway. So this is also from the pathway, and it shows you if you have an abnormal finding on exam, what the recommendation is based on age. There are 3 categories. There are recommendations in our pathway for women who are under 30. There are recommendations for women between the ages of 30 and 39. And then again, fairly similar recommendations for women over 40. And so this, going back to the case, she went on to have a biopsy, and the biopsy showed that she indeed had an invasive ductal cancer, which was grade 3 estrogen receptor positive, PR positive, and also HER2 positive. And so the picture on the right is just showing you that when a woman is diagnosed with breast cancer, before starting treatment, it's really important to know what subtype of breast cancer that woman has. And these patients who fall into these different categories will be treated differently, because when a woman's diagnosed with breast cancer, the treatment is very individualized and very unique and very personalized. Next slide. So because she was HER2 positive, I referred her to Dr. Rozenblit. So she was referred to medical oncology before the start of any treatment. And this is known as our multidisciplinary approach. Again, knowing what subtype is a key factor in determining what systemic treatment is needed, and whether or not she should have surgery before needing any systemic treatment. So this patient in particular, she underwent chemotherapy first and then surgery. The decision to do a mastectomy or a lumpectomy is dependent on a lot of different factors, and those factors are extent of disease, breast size, comorbidities, genetic status, and prior radiation. So she went on to have chemotherapy first, followed by a lumpectomy, and then will eventually undergo radiation. Mariya, do you want to talk about her systemic treatment?
Yeah, absolutely. So especially in HER2 positive and triple negative breast cancers, because they tend to be more aggressive and require chemotherapy most of the time, it's really important to have this multidisciplinary discussion up front. 2 centimeters tends to be the cutoff where we start to think about doing chemotherapy and treatment before surgery. And that gives us really important information. One, it helps us see how the tumor is responding during treatment. And when they get to surgery, we're looking for something called a pathologic complete response, which is we hope that after all the treatments and chemotherapy that we give, that there will actually be no tumor left at the time of surgery. And that's very important in terms of prognosis, and really predicts a very low risk of the cancer reoccurring or coming back in the future. Another really important reason why we think about this up front is that there are a lot of clinical trials in this space right now as well. And a lot of the clinical trials are focusing on de-escalation. So thinking about how we can give less toxic chemotherapy in this space, and also more targeted therapies. So there are newer treatments coming out, such as antibody drug conjugates, where we're actually targeting the chemotherapy more closely to the tumor, being able to deliver lower doses of chemotherapy and being able to give less toxic treatments to these patients. So very important to have these multi-D discussions and also to think about whether there might be a clinical trial available for a patient as well.
That brings us to our third case. This case is a 74-year-old woman who had a normal mammogram about 6 months prior to the visit. She has a history of hypertension, reflux, and skin cancers, and she presented for her annual exam and just had happened to note some mild right breast fullness for the several days prior to her appointment. Her medications were metoprolol, omeprazole, and spironolactone. She's a non-smoker, no alcohol, quite vigorous, very active, and exercises quite a bit. Family history was significant for a mom who had breast cancer at age 68 and was still living. Brother had prostate cancer. Another brother had esophageal cancer. She is of Ashkenazi Jewish ancestry on both sides. Her mammogram and ultrasound 6 months prior just showed some coarse calcifications and several cysts, but no pathologic findings. Her exam was interestingly notable for some palpable fullness on the right lateral breast only, and only when examined in the supine position. It was a very a subtle finding that the clinician was able to achieve in that. She did, unfortunately, have a diagnostic mammogram that demonstrated a 1.4 by 1.2 irregularly shaped hypoechoic mass with indistinct margins, with an adjacent irregular mass as well, and a possible third mass. And this was a BI-RADS 4. Her biopsy, 2 biopsies revealed invasive lobular carcinoma and invasive ductal carcinoma with atypical ductal hyperplasia. She underwent MRI to assess for escalation of disease or concern for more persistent disease, but no additional disease was found. At lumpectomy, she had lobular and ductal carcinoma, both ER/PR positive, but HER2 negative, and her genetic testing was negative. Her Tyrer-Cuzick assessment was 7% when you put in all of her categories. So by genetic testing and by risk assessment, this was not someone that would have been captured earlier. So there are a couple of questions that I pose. One is, let's talk a little bit about physical exam, and the United States Preventive Task Force doesn't recommend clinical breast exam. So I'd like to hear your thoughts on that for the community here.
I think it's still important to perform a clinical breast examination on patients, and I often have patients ask me if they actually should do a self breast exam. I counsel patients that it's important to have an awareness of any change in the breast and really, paying attention to any new findings, such as an inverted nipple or a new dimple in the breast or any palpable mass. So I think that certainly it gives us the ability to diagnose these cancers earlier.
Yeah, I completely agree. I think rather than thinking about it as searching for a mass, it's about kind of being aware of your own breasts and being familiar with them. So that if you do notice something new or different, especially skin changes, nipple changes, that's something that you might notice if you're kind of used to looking at the breasts, and then you can reach out to your primary care doctor and evaluate it further.
Thank you. Yes, it is my practice to perform a breast exam, and I have this similar conversation with my patients about knowing their own breasts and making sure they point out any new findings, which was the case for this particular patient, and her clinician astutely performed an exam. Can we also talk a little bit about, in this case, the utilization of MRI after biopsy and when MRI gets used? Sometimes MRI is used before surgery in terms of extent of disease. Would you comment on that as well?
I think possibly in this particular person or other patients, after we get a diagnosis of breast cancer, if the breasts are dense, and so this is common in younger women, we do recommend, or sometimes we'll get an MRI to assess extent of disease because of the limitations of the mammogram and ultrasound. So when the breast tissue is dense, we would add an MRI for evaluation of extent of disease before surgery. That's one reason for getting the MRI. And then in this particular case, she had a type of breast cancer, which is a lobular cancer, in which we know that mammography and ultrasound has limitations in detecting a lobular cancer. And so I think an MRI in the setting of a lobular cancer is important before proceeding to surgery, because you want to make sure there's no additional disease before the operation.
Yeah, I completely agree with that. And there's been literature documented that shows that lobular cancers not infrequently are upstaged on breast MRI. It's just harder to see the extent of the size of the tumor and lymph node involvement on mammograms and ultrasounds. And so a lot of times it's just important to get an accurate size, especially for surgical planning. And if you're thinking about potentially trying some therapy to decrease the size of the tumor before surgery, to think about an MRI to get an accurate size.
Yeah, certainly an MRI is not needed in all patients before surgery. So if a woman is not dense, if it's a small early detected cancer, sometimes we don't get an MRI. So it's a case-by-case individual approach.
Thank you. Before we go on to discussion of annual screening and limitations of screening modalities, this particular patient has a 44-year-old daughter. So could you talk about how we would approach, how her primary care doc should approach screening her going forward?
So I think she should undergo annual mammography. And if she has dense breasts, that could be supplemented with an annual ultrasound. I think she can be referred to a high-risk provider, and we have many high-risk providers throughout the Yale New Haven health system. And the high-risk provider would then use one of the risk models, such as the Gale model or the Tyrer-Cuzick, to determine her lifetime risk. And then based on her lifetime risk, she may or may not qualify for an annual breast MRI if her Tyrer-Cuzick's greater than 20%.
Thank you. So I think oh, go ahead.
No, just sort of getting to the next part on the slide is, when should we stop getting mammograms on our patients? I think in general, I think mammography and breast screening should continue. I think that you can consider stopping screening mammograms if a patient's expected life expectancy is less than 5 years. And obviously additional comorbidities and not just age is important when determining when to stop mammography on our patients.
Yeah, and just to add to that, from an oncology perspective, most of our treatments are based on comorbidities and performance status. So if somebody is overall healthy, doesn't have a lot of comorbidities, and has a life expectancy that's greater than 5 years, a lot of the times they would be eligible for treatment. So it's certainly reasonable to continue screening. And if those cancers are found and they have a good life expectancy, it certainly makes sense that they would be treated for that.
I think that it does become a conversation where patients are used to getting their annual mammogram. I think we see in primary care both elements where I have some patients who I think are incredibly healthy. I perceive them as incredibly healthy, and what we would pursue treatment if they had a cancer found, who are really just want to end screening and don't want to do any more preventive care. And then I have patients who are much older that I would have conversations, consideration, maybe not based on some based on comorbidities, but maybe really just reaching advanced age where we may be finding a cancer that might not have made a big difference in their life and may not have been something that really required treatment, and then potentially putting someone through an unnecessary test. So I think those conversations are equally difficult because people are really attached to that screening modality and feel that it's really important to their health. How do you address some of those concerns in terms of patients who don't want to ever give up screening mammograms? Because, you said 5 years, some institutions recommend over 75 or with 10 years, less than 10 years of life expectancy.
I think exactly what you talked about is correct. Using that shared decision-making model and seeing what the patient wants. Certainly I recently had a patient who was 91 in the office and she was great. And I put in a referral for her mammogram next year. I think it has to be an individual approach.
Yeah, I agree. I think it's a very individual approach, and we really have to take into account the patient's goals as well. And I think that if they are at an advanced age and they're not interested in continuing screening, I think that's okay too. I think that if something were to become significant, that will be palpable. And Dr. Gillego and I have certainly seen patients who are elderly who have come to us because of a palpable finding, and we're able to treat that as well. So I think it goes both ways. I think breast cancer is a little bit unique in that a lot of our treatments are a lot less toxic than some of the other cancers. So it is one of the few cancers where we think about continuing screening probably longer than we have to. And a lot of that has to do with, even if something is found, we're often able to find a treatment that's not too toxic and can still preserve the person's quality of life if they need treatment.
And then just going back to screening in general, the USPSTF and the American Cancer Society, while they don't recommend annual mammography for women of certain ages, I believe it's still covered by insurance companies.
Yes. And I also think just remembering that when you do have a woman that has a higher risk, that you are diligent about making sure she does have her annual mammogram, or certainly for women who've had a prior history of personal history of breast cancer as well, being attentive to that and not just making sure you're following the higher risk model rather than an average risk model for that population of patients.
And I think it's also important to really remember that the rule of starting annual screening for breast cancer in women 10 years before the age of diagnosis of a first-degree relative. And so that's a mother and sister. Going back to case number 1, this is a woman who was 42 years old, and her mother was diagnosed with breast cancer at 40. So she should have started her screening at age 30. So just going back to that 10-year rule, 10 years before the age of diagnosis of a first-degree relative.
That's a great pearl. Thank you. Anne, are there any questions in the chat that we should talk about before any additional final points?
There are not questions in the chat. I will encourage our listeners to add questions to the chat for consideration. Why don't you wrap up with some final points to share? And then I know I have a couple of questions, and Jill, you may have some additional ones too.
Sure.
So we'll stay on a little bit.
Sure. I do think that, oh, go ahead, Mariya.
No, go ahead.
Oh, no, I was just going to say that just the conversation really has been focused on assessment of risk. So I'm going to turn it over to you now.
Thanks. So as we talked about, it's very important to evaluate each patient's risk beginning at age 25, and then to repeat it every 5 years, as there might be changes in family history that somebody's not necessarily going to bring up unless you ask. When you take the family history, it's really important to ask about everyone, including both sides of the family, and be sure to include those without cancer. So in all of these risk models, it's important to put the healthy relatives as well, to have that accurate denominator, as Jill mentioned. People also assume that they don't have to think about male relatives when it comes to breast cancer. And so it's important, once again, to ask about all relatives. Things like prostate cancer that affect men tend to run with breast cancer and BRCA and other mutations. So very important to get a full history. And of course, pancreatic cancer, which is associated with BRCA, can be either in men or women. It's important to think about when to refer to genetics. And so a lot of that is based on the family history, as Jill mentioned. And then please refer to our care signature pathways. We have spent a lot of time and we've had a lot of experts look over these pathways, and they can be incredibly helpful to turn to, just to kind of see the overall flow and when to refer, and when to think about next steps. And then to think about appropriate screening based on risk. So how frequently to do mammograms, when patients might be eligible for additional imaging like breast MRIs. And then of course, a multidisciplinary approach to taking care of these patients. We often have, of course, primary care physicians, as well as breast surgeons and medical oncologists, and radiation oncologists that are all involved in the care of these patients.
Good. Thank you. That was terrific and a lot of very good take-home points. We do have a question, and that's from Marguerite Pinto, who asks about postmenopausal women with dense breasts having an ultrasound. So I think this refers to a Medicare decision about a year and a half ago, although most of us missed it at the time, where dense breast screening ultrasounds are no longer routinely covered by Medicare. What we've learned is that if it's diagnostic because of something palpable, of course it is covered, but the kind of knee-jerk ultrasound with mammography is not routinely covered. Are they still necessary? What are the chances of missing something without it?
Oh, I think if a patient has dense breasts, we do recommend supplemental screening because of the limitation that mammography has. And I think in addition to Medicare, for those patients who do have a private payer or private insurance, it's really, some insurance companies right now are covering ultrasound and some are not. So I think that can be discussed as well.
Yeah, I don't know the statistics, but we certainly have cases where unfortunately a mammogram missed something because the breasts were dense and then it was caught on ultrasound. So it is important to try to get the additional imaging when we can. I think that perhaps this came about because dense breasts are just less common in postmenopausal women, especially compared to younger women, but we do see that sometimes, and it is helpful to have that ultrasound.
Want to pull out maybe a part of case 3, which is this concept of, a breast cancer that arose shortly after a normal mammogram, right? And, of course, there's an existential angst of this is just not supposed to happen. This woman did everything right. She had her mammogram just on time. How often do you see this? I mean, you guys practice in a very enriched environment of people with cancer. You hear their initial stories all the time. Are we doing enough with our screening? Is it all high-risk patients who come in with these intercurrent cancers, or does it just happen even with average risk individuals?
Right. So the development of a cancer in a woman who had normal imaging the year prior, that's called an interval breast cancer. And it does happen, and that's the reason to emphasize the importance of annual screening, because A cancer can appear 1 year and not have been there the year prior. It happens. I think what case number 3 highlights is the fact that this woman had normal imaging and she came in, and even though she had normal imaging 6 months prior, the primary care provider knew that her imaging had to be updated, and that led to her early diagnosis.
I think overall, in the grand scheme of things, interval breast cancers are rare. We tend to see them more in the aggressive subtypes like triple negative or HER2, and it's much less common in hormone positive breast cancers, which do tend to be slow growing. And so in general, imaging once a year is very sensitive, and overall does a great job of catching these cancers. Our imaging is also not perfect on its own. And so if something is very, very small on the date when the imaging was done, it just can't be seen. It has to be a certain size to even be seen on a mammogram or an ultrasound. And so this person might have just been unlucky and it was something tiny. And then 6 months later, it was actually big enough to finally be caught on imaging.
I have a question. If you don't have another one in the chat there, Karen.
Go ahead.
I have the one modality that we didn't talk about for risk reduction. We talked about tamoxifen, but we didn't talk about surgery. And when do you all recommend bilateral mastectomy versus chemo prevention? In which cases?
Yeah, so certainly in a woman who carries a BRCA1 or a BRCA2 mutation, these women are eligible to undergo risk-reducing surgery, and that's with bilateral prophylactic mastectomy, decreasing their risk to less than 5%. And so in the office, we do discuss with them, they have the option for increased surveillance, which is a mammogram, plus or minus an ultrasound, alternating with MRI every 6 months, or going ahead with the surgery. It's recommended to undergo that surgery in a woman who carries one of these genetic mutations after they've completed having at the age of 35 or after they've completed childbearing and breastfeeding. There are other genetic mutations, and I think for the other genetic mutations, if a woman tests positive for genetic mutations like CHEK2 or PALB2, we really have to combine that mutation with the incidence of breast and ovarian cancer in the family, and then we can discuss what their risk is and the option for prophylactic surgery.
Yeah, I completely agree with
Go
that.
ahead.
And in general, the consensus is that even when we talk about patients who are at this increased risk, in order to go through a prophylactic surgery, the only risk that's high enough to warrant that is a genetic mutation, like Dr. Gillego mentioned. And in all other cases, our screening is very good, surveillance. And then we also have the option of chemo prevention for those women as well.
Yeah. Sort of an unrelated topic, just going back to case, I think it was the first case number 1, that's the young woman, 42 years old, who was diagnosed with breast cancer. And so she eventually underwent mastectomy on the cancer side, and she opted to undergo a prophylactic left mastectomy. I think it's important to point out that the removal of the contralateral breast or decision to undergo a bilateral mastectomy, removing the breast that does not have cancer, doesn't improve her prognosis. And that's a personal choice, but it doesn't improve her prognosis or decrease the risk of developing cancer a new cancer in that contralateral breast. So that's important to point out, that if you get diagnosed with breast cancer, you don't have to undergo a double mastectomy. And then one thing I just wanted to also add is that when we discuss what a woman's risk is of getting breast cancer, I think it's important then to talk about what are the modifiable risk factors, the risk factors that patient can change. And so this is counseling your patient that while breast cancer remains the most common cancer in women, it's important to lead a healthy lifestyle, eat a plant-rich diet, avoid smoking, minimize alcohol, and the American Cancer Society recommends at least 2.5 hours of exercise a week to decrease cancer risk.
Yeah, fortunately for us in primary care, that's what we're talking about for everything, whether we're
Everything.
talking about the heart or we're talking about cancer. So there's kind of a funny theme that goes through a lot of our visits, but it is really important. And using a reason unique to the patient is so helpful. I just want to take the prerogative of one final question, which is, genetic testing and high risk clinicians are really wonderful. I mean, it really does open up a whole nother level of, screening, discussion, chemo prevention, but it is a limited supply. And, the concept that spreading some of this to primary care and to the gynecologic community is the other community in breast seems really important. Where do you think this will go in the long run?
I think that's a great question. I wish we had enough manpower, like you said, to have more and more of these clinics. And in reality, there are more women that are at increased risk of breast cancer. And as we start to screen more and more of them, we're realizing that we just don't have enough people to staff all the patients that need to be seen. And I do think that a lot of these discussions can come from primary care and OBGYN, as you mentioned. And ideally, I think what we would have is more advanced practice providers that can take on these discussions as well. And there are some really wonderful courses out there to train nurses and advanced practice providers to kind of become more educated about these issues and to start counseling these patients. And so I think that's the direction that we should go in and just start to have more providers that are able to have training in this and to have more of these discussions.
Yeah. And then just to add, if you are on Epic through the health system, you can put a referral for genetics, and the Yale genetics team will reach out to your patient to schedule that patient based on urgency.
And I
And
just,
Don DiGiacomo also just put in the chat that there's another care signature pathway coming specific to genetic cancer screening, which should, I guess, open the ability to order testing without genetics consult, and then having the genetics consult if it's positive, which is another way of sparing resources. So that's exciting too.
Yeah.
Point of-
And the
point of
results.
care testing.
Yeah. And the genetic
Oh,
results.
I see.
Yeah. And the genetic results are now available on Epic.
Yeah. Okay. All right.
Yeah, I think working collaboratively with our colleagues and to potentially be ordering genetic testing and have genetic counselors help us with delivery of results and assessment of risk and more patient information, which can be found in the care signature pathway to describe to patients what is involved in genetic testing. I think all of that will improve access.
Yeah. Okay.
We'll do that topic next year.
We did it 2 years ago. We'll bring it back with the new developments. Good.
So we do have coming up in May gammopathies that was requested, and then in June colorectal cancer prevention screening. And when this ends, you'll get a survey. So make sure and fill that out so you can get the CME credit. Thank you so much to everybody. This was really interesting and so well prepared. Thanks again so much, and everybody happy spring.
Thank you.
Thank you.
Thank you very much.
Bye.